a bit less time, so I will go
Sorry,
little faster. Yes, tell me.
All the GLUT transporters for facilitated diffusion?
Yes, GLUT.
Okay.
Only this is secondary active.
For S-GLUT, yeah.
This is, except this, all are facilitated diffusion channel. Got that? Now. So we will talk about mucopolysaccharide. So mucopolysaccharide is heteropolysaccharide. We have already done about homopolysaccharide. We will talk about mucopolysaccharide. So this mucopolysaccharide is present where? It is present below the tissue. It is subcutaneous tissue or connective tissue. It is present in connective tissue. So you know connective tissue is present below cells. And actually connective tissue provides attachment of the protection of tissue and covering of the tissue. So this is connective tissue. So you know connective tissue has got this mucopolysaccharide. What is the function of this mucopolysaccharide in connective tissue? It will act as molecular sieve. When this is like this, so it will actually absorb water. It will retain water because you know this mucopolysaccharide, as the name suggests, muco. So you can see the muco means the water retention. Mucus is water retention. There is some protein and that is retaining water. That is why it is muco. So this is mucopolysaccharide because it retains water in it and it forms a mucus-like thing. And that is why it is also called molecular sieve, that actually retain water in connective tissue. So this is the water retention mechanism. This is the water retention molecular machinery. So you have to remember mucopolysaccharides are water retaining molecular machinery in connective tissue. And this other name of this is also called glycosa aminoglycans. You can see name. In short, you can see GAG. Glycosa aminoglycans. So why do we call it glycosa aminoglycans? Because it is polymer of a dimer. It is a polymer of dimer that made up of sugar acid. And then sugar amine. Sugar acid and sugar amine. This is polymer of disaccharide of sugar acid, sugar amine. Now, sugar acid is derived from glucose, called gluconic acid. Glucuronic acid. Glucuronic acid. Glucuronic acid. And then this sugar amine is derived from glucose and galactose. They are glucosamine, glucosamine, or galactosamine. So did you understand this simple thing? What is mucopolysaccharide? What is glycosaminoglycans? What is the function? Function is to retain water in connective tissue.
Yeah.
And then it is a molecularly, it is a disaccharide, polymer of disaccharide. One is sugar acid, one is sugar amine. Okay, so you can remember this way through this simple SASN, polymer of SASN.
But doctor, it comes sometimes as a question, right? Which one is absorbing? Like they will bring a case and say to you, which one is absorbed, right?
Yes, which of the following extracellular molecule that help in retaining water? So this can come like that. Actually, what I want you to understand, try to always think about in picture of your body tissues. So there is connective tissue below skin, and in that connective tissue there is water, and water retaining mechanism, water retaining machinery is this mucopolysaccharide. Predominant machinery is mucopolysaccharide. So that is what you have to memorize conceptually.
Oh, does that mean that hyaluronic acid, for example, is a mucopolysaccharide?
What is
hyaluronic acid? Does that mean that
yes,
is?
yes, it is a mucopolysaccharide.
Right.
Hyaluronic acid is a mucopolysaccharide. I'm going to talk about that. It has one sugar acid and other sugar amine. Sugar acid, sugar amine. Sugar acid is made up of glucose. Glucose. It is made from glucose. It is called glucuronic acid. Glucuronic acid. And then glucuronic acid. It is glucuronic acid. Glucuronic acid. Glucuronic acid. Okay. So this is glucuronic acid, and this is glucosamine and galactosamine. So we will talk about structure. See, you can see this is there different types of heteropolysaccharide. This is hyaluronic acid, as you have spoken. So this is chondroitin sulfate, and this is heparin. As I have already told you about heparin. Heparin is a heteropolysaccharide, and it is an anticoagulant. You can see other name is dermatan sulfate, other name is keratin sulfate, and you don't have to memorize them all. I will tell you what to memorize. Just you need to understand this dermatan sulfate, and there is one more. So heparin sulfate. From heparin, there is one more heparin sulfate. You need to know about only two. Heparin sulfate. So dermatan sulfate and heparin sulfate you need to know. As the name suggests, it is related to skin, derma, and heparin sulfate. We will talk about these two. Now let's see distribution of where this present. Now let's see what we have. I have told you it is a repeat of disaccharide. Disaccharide made up of sugar acid and sugar amine. Can you see here? Glucuronic acid, glucuronic acid group here, same like glucose but acid group 6 carbon.
Yeah.
Yes, and can you see amine, glucose, amine
with NH3.
Yeah, NH2 is
NH2,
present.
sorry.
Yes, and on this NH2 acetyl is present. That is why it is called N-acetyl. Anyway, it is a glucosamine. So it is repeat of sugar acid, sugar amine, and other places you can see sugar acid and then galactose amine here. Sugar acid and sugar amine. Now this glucuronic acid converts into different type of acid by an enzyme called 5' epimerase. Just simple isomerization. So glucuronic acid will isomerize into a different type of acid. Actually, it is same. You can see here above COO group, here below. That's the difference only. So it is similar to glucuronic acid. It is called idiuronic acid. So idiuronic acid, this is also sugar acid, and you can see galactosamine, galactosamine. So it is sugar amine, sugar acid, sugar amine, sugar acid, sugar amine. Here also sugar acid, sugar amine. Here also sugar acid, sugar amine. Now for heparin also sugar acid, and then this is also glucosamine. This is sugar amine. So you can see the repeat of sugar acid, sugar amine, except this. Here you don't see sugar acid. So don't remember that also for the time. Just remember it is this heteropolysaccharide are repeat of sugar acid and sugar amine. So will you remember the structure of heteropolysaccharide?
Okay.
General, yes, general structure as repeat of disaccharide of sugar acid, sugar amine.
Yes, we are able to. Okay,
so that is what you need to remember. Now let me see. So you can classify this into two groups. What happens is certain this heteropolysaccharide, you will see additional group on this. You can see sulfate group here. So this actually, this is negatively charged. It will attract water. That is why these groups are present. It will attract water. This all negative charge. This sugar will also, this acid will also attract water. That is why this negatively charged are there. So sulfate, many sulfate, you will see sulfate in heteropolysaccharide. So heteropolysaccharide is also has sulfate group at different position. With sulfate, there will be acetyl group. You can see acetyl group are present. Sulfate and acetyl group. So this makes this heteropolysaccharide more negatively charged. And based on that, this is classified into two groups. One is acidic, where you will see sulfate group is present, other is neutral, where sulfate group is not present. So these two are neutral. Hyaluronic acid, if you can see, hyaluronic acid does not have sulfate here. And then you can see dermatan sulfate, heparin sulfate has sulfate. So, and these two dermatan sulfate and heparin sulfate we will talk more about. So you can see general distribution, but we are focused on dermatan sulfate and heparin sulfate. Let's talk about dermatan sulfate, where it is present. So you need to memorize about this only. If I tell you to memorize all, you will memorize nothing. So better focus on one. So dermatan sulfate, if you can see, as the name suggests, skin, and that is why it is present in skin, and it is present in blood vessel valves, heart valves, okay, and it is present also in cornea. It is not written here, it is present in cornea. So you can see cornea, blood vessels, blood valves, heart valves, blood vessels. So these all places, in these places, this dermatan sulfate is present. This dermatan sulfate is present. Maintain shapes of tissue. Now you can see here. So dermatan sulfate, in addition to this heart valves, it is present in a sclera. I told you cornea is sclera. This is a sclera of eye. So sclera, skin, cardiac valves, and then tendons. These all places dermatan sulfate is present. So we will need this when we study disorder. So iduronic acid, if you can see iduronic acid, it is as I have told you, dermatan sulfate. Let's see the structure again. You can see in dermatan sulfate, iduronic acid is present, not glucuronic acid. Okay, so we will need that also. So which acid? Sugar acid is iduronic acid is present. So we will need this iduronic acid. Sugar acid here in dermatan sulfate is iduronic acid. In heparin or heparin sulfate, it is here also you will see both type of. So here also you will see predominantly iduronic acid. So though in heparin sulfate. So iduronic acid we need that, and they are distributed among these tissues. Okay, role of this dermatan sulfate. What is the role of this dermatan sulfate? For corneal transparency along with keratin sulfate. So dermatan sulfate is present in cornea. It helps in corneal translucency. Because of that, because cornea is transparent, we are able to see the image. So you can see here heparin sulfate. So heparin and heparin sulfate are almost equal, but heparin sulfate has more sulfate and more iduronic acid. You can see iduronic acid will be high. Iduronic acid will be here. Actually, both have iduronic acid, so there is no that much difference. Okay, so it is, just remember, it is very similar to heparin and heparin sulfate. They are very similar, but only main difference is heparin you will see in intracellular. This is the only heteropolysaccharide that is present inside cell. Otherwise, all heteropolysaccharide is present outside the cell, because heparin function as anticoagulant. That is why it is inside the cell. Okay, so both are almost similar. It has iduronic acid. Remember iduronic acid. No. So mucopolysaccharide you have seen. So what will happen? Let's talk about the disorder of mucopolysaccharide. Two disorder. So you will see in mucopolysaccharide disorder these features. You will see skeletal manifestation. Bone, you will see bone manifestation. So bone manifestation, brain manifestation, then cornea manifestation, cutaneous manifestation. So bone, brain, cornea, cutaneous. What mnemonics came? BBCC. Bone, brain, cornea, cutaneous. So 4 type of manifestation you will see in patients with mucopolysaccharidosis. So what is mucopolysaccharidosis? So mucopolysaccharidosis is the disorder which result because of deficiency of certain enzymes. The enzymes is present in lysosome. So it is intracellular problem. Lysosome is present inside cell. So these enzymes are present in lysosomes. If certain enzymes are deficient, this will not allow heteropolysaccharide to degrade. And if it is not degraded, this glycosaminoglycan or mucopolysaccharide will accumulate inside cell. And because of accumulation inside cell, it will cause disorder. There will be problem with the bone. There will be problem with the brain. There will be problem in cornea. There will be problem in skin. So this mucopolysaccharide will deposit below skin in the bone. And actually, because of that, brain development will also be slow. Because brain is present in cranium. So brain development becomes slow. Bone development has problem. It will be slow. Corneal clouding will be there. And then cutaneous skin will be rough. So these are the presentation because of deposition of this glycosaminoglycan inside cell. So we will talk about these two disorders. One is Hurler syndrome, other is Hunter syndrome. Hurler, so we have many. If you try to focus on many, you will not remember anything. So I want you to remember these two. If you remember these two, sooner or later you will understand these three. Just understanding of these three is required. Not, you don't need to memorize. So these are the high yield things. So the question will come from these two. So Hurler and Hunter, you will see this is the most predominant disorder. These two are most predominant. You can see Hurler syndrome is because of deficiency of iduronate. That is why I want you to memorize this iduronic acid. So this is because of deficiency of iduronidase. And if iduronidase enzyme, this is a lysosomal enzyme, and these all disorder are lysosomal storage disorder. What does lysosomal storage disorder means? If there is deficiency in lysosomal enzyme, it will cause accumulation of substance inside cell. This is called storage disease. The storage of this glycosaminoglycan increases because of defect in lysosome. Because of defect in lysosomal enzyme. That is why lysosomal storage disease. Because of deficiency of lysosomal enzyme, storage of glycosaminoglycan increases. So this such type of disease is called lysosomal storage disease. And this all mucopolysaccharidoses are lysosomal storage disease. So you can see here, this is first is autosomal recessive disease. This is X-linked disease. The very basic difference. X-linked, autosomal disease. In both cases, you can see heparan sulfate and dermatan sulfate are accumulated. Heparan sulfate and dermatan sulfate both have iduronic acid. So if enzyme that will actually degrade this hyduronic acid, that will actually remove the hyduronic acid from this disaccharide, which cut bond and remove hyduronic acid. If this enzyme is absent, so what will happen? There will be increased accumulation of glycosaminoglycan. And you can, if you can see this, there is second enzyme, iduronidase sulfatase. So what happens? What does this enzyme do? There is sulfate group in iduronic acid. So this will remove sulfate group here. So which is the more important enzyme among these two? This is the more important enzyme. And that is why if this is present, absent, the disease will be severe in comparison to this. So this is the two. There is severe presentation you will see in this. This is milder presentation in comparison to this you will see in Hunter syndrome. So Hurler syndrome has severe and Hunter syndrome has milder presentation in comparison to each other. This is because of X-linked disease. This is because of autosomal disease. Autosomal recessive X-linked. Both cases, heparan sulfate and dermatan sulfate is deposited. Okay. Now, did you understand? So it will be more clear here. You can see. This is Hurler syndrome. Hurler syndrome, what is the cause? Deficiency of this enzyme, iduronidase. Iduronidase. ID card, you can remember ID card. From ID card, you can remember uronic. So iduronidase. You can remember from your ID card, iduronidase. Deficiency will cause Hurler. So what happens? So this heparan sulfate and dermatan sulfate will deposit in different tissue, cornea, skin, bone. And because of that, what will happen? So mental retardation will be there. Progressive mental retardation.
Doctor, is it common in female or male?
This is autosomal recessive.
Yeah, so it will
When
be
it is both, it will be present
Yeah.
in both sexes. Okay, there will not be sex differentiation. But when it is X-linked, this will be present more in male. X-linked male will have more disease. Okay, male will have more X-linked disease because female has 2 X chromosome.
Yeah.
If
Mhm.
one chromosome has problem, other chromosome is fine, so female will be saved from the disease. Get that?
Yes, yes. Thank you.
Okay. So you can see this is the, so you can see here corneal clouding. Corneal clouding you will see here. Gorgoyle-like face you will see this type of. So rough skin, gorgoyle-like face, short height will also be small because of bone problem. So height will also be short. Face will be like very abnormal type of very not good looking face, ugly looking face, gorgoyle-like faces you will see. Corneal clouding you will see in such patients. So these are the presentation. There can be heart problem, liver problem, kidney problem associated with this. So multi-organ failure you can see in such patients, organ failure. In addition, these are the key presentation you will see in question. Along with this key question, there will be organ failures. Okay, so and then this is Hurler syndrome. You can see the face. Eye will be separated apart. This is called hypertelorism. You can see hypertelorism here with depressed nose. Nose are depressed. So mental retardation, this frontal boozing, because of this heparan sulfate and dermatan sulfate decumulation, there will be bulging of this forehead. Here you can see this is called frontal boozing, and then the gap in teeth because of deposition of this heparan sulfate and hyaluronic acid, heparan dermatan sulfate in bone. This bone will grow and teeth will become apart, so gapped teeth. So these are the presentation because of deposition of heparin and dermatan sulfate, and that happens because of deficiency of iduronidase. Okay, so you can say this is actually a spectrum of syndrome. You don't need to actually, so this the very attenuated form are called C syndrome, and very severe is called Hurler syndrome. So just for information, these are a spectrum of disorder. Sometimes you will see Hurler syndrome with very mild presentation. This is called C syndrome, and in between it's called Hurler C syndrome. And that is why if you can see, I have written here Hurler syndrome, Hurler C and C syndrome. Now, so you can see this is corneal clouding, and for Hunter syndrome, corneal clouding is not present. This is the very important finding. For Hunter syndrome, clinical presentation, corneal clouding is not present. This is absent. So in Hurler syndrome, you will see corneal clouding. Here, you don't see corneal clouding because you know the enzyme is iduronidase sulfatase, and this enzyme is required not, but it is not as important as the enzyme that you have seen before. It is not as important as iduronidase. It is also important, but if you compare with this, it is not as important as this. And that is why deficiency of this will cause severe disease. And this deficiency of this causes a milder presentation. Severity is less, but behavior is aggressive behavior. So these are the presentation difference between Hurler and Hunter. So you can see these are the differences. But here you will find kidney damage. Here you can find liver damage, but milder. You will see stunted growth. You can see stunted growth here also, but it will be milder in comparison to Hurler syndrome. It will present in male because it is X-linked disease. So men, remember this difference: corneal clouding and less severity. Okay. So did you understand the difference between Hurler and Hunter syndrome?
Sorry, you said Hunter's always male?
Yes. Can you tell me, please? Hunter? Yes, ma'am.
Sorry, you said Hunter is always going to be a male, right? And Hurler can be male or female?
So yes, Hunter, because it is X-linked.
Oh, right. Okay.
Hunter is X-linked. That is why it is present more in male. Hurler is autosomal recessive. Okay.
So we need to know these two for the test on Monday, right?
Yes, you need to know this too for the test. And one more disorder we have, this eye cell disease. So eye cell disease is disease that actually combine two disorders. This is called this is called mucolipidosis. Sphingolipid plus muco. So we will talk about this sphingolipidosis later. So this combine two features together. And you will see more pronounced feature of this mucopolysaccharide. Here also you will see BBCC type of presentation, but very severe. It is the very severe, severest of all kind we have studied. So you can see very stunted growth here. Baby will not grow. And here this happens because of this defective lysosome. Previously, the disorder we studied, those disorders are because of deficiency of one enzyme of the lysosome. Here, the whole lysosome is missing. This disorder is because of the whole lysosomal enzyme is missing. This is because of empty lysosome. This is the disorder of empty lysosome. So lysosome does not have any enzyme. And that is why this disorder will happen. This is called eye cell disease. This is called eye cell. Why eye cell? Eye cell for inclusion cell. Inside cell there will be many inclusion bodies.
Doctor, why lysosome is not there?
Yes?
Why lysosome is not there?
Yes, that is a good question. I'm going to talk about that. Okay? Why it is not present. So so when you send somewhere, this is like a home. A person is here. So use other person. For example, you send a message to other person. For example, you send a letter to someone. So don't you think your letter need to have address to reach here?
Yes, of course.
Yes, of course. Even if you send a mail, there has to be email ID. Otherwise, if you don't add email ID, it will not reach. So this letter has to have address. The same way, when inside cell, the same analogy is true. When there is a cell, in cell, what will happen is protein synthesis will happen in ribosome. Okay, protein synthesis will happen. So protein synthesis will happen in cytosol. And in order to reach this protein somewhere in lysosome, this protein need to have an address. This protein need to have an address. Actually, address is present at the terminal end. So if this protein does not have address, it will not reach, it will not enter inside this lysosome. So this is the basic problem in lysosomal storage, this eye cell disease. This address is missing. Address is missing.
For why, doctor, is it like for X-ray, like maybe?
No, X-ray, from X-ray you will not find molecules. I will tell you what is this address is. So did you understand up to this? Address is missing.
Yeah.
Problem is address. What is this address? I will tell you. Now you can see this. So this is the protein. You can see this is a protein. This is the protein. This protein has to reach lysosome. But in order to reach this protein lysosome, this protein need to have an address called mannose phosphate. This is called mannose phosphate. You can see. So enzyme defect is because of enzyme deficiency. The enzyme deficiency is an acetylglucosamine phosphotransferase. Just remember phosphotransferase at least. Enzyme that usually phosphorylate mannose. Okay, this phosphotransferase, which an acetylglucosamine phosphotransferase. This phosphotransferase enzyme is absent in cell, inside cell, in Golgi body, in Golgi, because this is present in Golgi apparatus. And if this enzyme is absent, then what will happen? The protein will not be, address will not be written on protein. What is the address? Is mannose phosphate is the address. So when mannose phosphate is not added here, if this enzyme is absent, what will happen? This protein will not enter this. Normally mannose phosphate is added through this process. You can see this is UDP glucose. From UDP glucose, phosphate is transferred like this. So this is UDP glucose. So UDP glucose, you can see first whole UDP glucose will be added on the mannose here. Now here this will be clipped and glucose will be removed and phosphate will be present permanently here. So this is address. This is signal. This is called signal. Mannose phosphate. This is a signal. If this is absent, so the lysosome will be empty. Did you get that?
Yeah, I got it, but I mean, why from the beginning mannose phosphate is like disappeared? Or...
So this is the enzyme that will add this address. If this enzyme is absent, so all protein, no protein will have address. This is the enzyme that writes address. You mean you can understand that way?
Is it inherited? Like,
yes, this is enzyme. That is why if there is deficiency in this enzyme.
Oh, okay. So inherited is okay.
Yes, inherited. All disorders are inherited disorders.
Yeah, thank you.
If there is deficiency in this enzyme, if there is deficiency, if actually gene is defective, then this enzyme will not be produced. This enzyme actually writes the address. What is address? Mannose 6-phosphate is the address. Mannose phosphate is the address. Mannose is a type of monosaccharide. Like glucose, mannose is also very similar to glucose. Remember, mannose is very similar to glucose. Very slight difference. Very similar to glucose. 6-carbon compound, similar to glucose. Slight difference is there. Actually, mannose is synthesized from glucose only in our body. So this is the address. Mannose 6-phosphate is the address. That address actually carry this protein to the lysosome. But if this address is missing, this protein will not enter. And address is written by this enzyme. You can see this enzyme written here.
So, doctor, why people who hold this enzyme like try to get babies? It's like
so people does not know.
Is it lawful to get like?
No, actually people don't know. People have 2 chromosomes. One chromosome is defective.
Yeah, I know, but
And
the genes, the genomic program now is very developed, so they can.
No, it is developed, so that is why prenatal diagnosis is done. And this disease diagnosed in prenatal condition, abortion is done, and people don't get baby that time. And if the parents don't undergo this prenatal diagnosis, they will have baby and they will suffer.
This is so sad. Like these pictures, it's like heartbreaking.
Yes, it is sad. It is sad. So I will tell you what will happen if these enzymes, if it is not entering, this enzyme lacking this address, mannose 6-phosphate, if it does not enter this lysosome, what will happen? This enzyme will come out in the blood. will rise in blood. And from blood, this enzyme, you test these enzymes and you find out the type disease. So here you can see this is enzyme. Because of this is a post-translational modification. And if this enzyme is deficient, this post-translational modification will not happen, and in this lysosome will be empty. Because of that, what will happen? The enzyme secreted extracellularly into the blood, and that is why high plasma level of lysosomal enzyme. So this can be used as diagnostic test. So this is the presentation. The similar, you will see similar but severe presentation. Mental retardation will be happen. Coarse face, you will see gingival hypertrophy, because this all mucopolysaccharide and this sphingolipid will deposit in bone, and corneal clouding, kyphosis. So this type of presentation you will see. The parent will have a very hard time with such kids. Okay. So did you understand about this eye cell disease?
Yeah, thank you so much.
No problem, miss. So if you have understood, so this is the question, you can go through this yourself. So actually we have, so 18-month-old girl is brought to pediatrician's office for failure to thrive, developmental delay. Patient's mother says she has not started speaking, it's just now starting to pull herself up to standing position. Okay, so 18-month-old girl. It's not started, just trying to stand up. Her movements appear to be restricted. Physical examination reveals coarse features and restricted joint mobilities. These are also very features of this lysosomal storage diseases, and this especially this mucopolysaccharides, because bone has problem, joint has problem. So laboratory studies shows increased plasma level of several enzymes. As I've told you, because enzyme will go into blood. So which of the following is underlying biochemical defect in this patient? So you can see easily, you can easily find failure of manage phosphorylation. Phosphotransferase enzyme is deficient. Okay. Which phosphotransferase? Glucosamine. Acetyl glucosamine, phosphotransferase. So with this